Akriti for involving me in this. It's such a pleasure to have two very old friends from oncology community chairing the session and two very eminent National Breast Committee members being here, Dr. Bhuyar and Dr. Charu. Very interesting what to do when CA breast is diagnosed. A very simple answer could be refer to an oncologist and rest. But I think it's not so simple. The responsibility doesn't end here. It in fact begins here. And we'll see how it begins here. I'll just go back a bit. Before diagnosis, how do we diagnose breast cancer? And very typically we say triple assessment, which is clinical, radiological and pathological. And if any of them is very suspicious and you are not getting a diagnosis of breast cancer, revisit the whole thing. You may need to repeat a biopsy, you may need to excise it if the repeat biopsy is also not showing cancer and still it is suspicious. So be very aware of discordance between radiology and pathology, clinical and pathology. The other debate which goes on and on is whether we do FNAC or we do a core biopsy. At least in oncology circles this debate has been rested now, and we must do a core biopsy, because on the surface every breast cancer may seem to be the same. It's breast cancer, but it is very different, and it is just as different as Ashish Nehra is from UK Prime Minister Rishi Sunak, right? Yeah, so we have to be very careful. We must do a core biopsy, we must subject it to immunohistochemistry so that we can differentiate between various types of cancers and then treat them accordingly. And before I move on, I'll just take 2 slides to say what not to do sometimes. In the previous panel discussion, there was a case where it was diagnosed after lumpectomy, which is not the correct approach. The first is to do a true cut biopsy, maybe repeat it one more time and then move on to lumpectomy. Now this lady had a lumpectomy. That's also fair enough, but if you see the yellow arrow right outside, almost outside the breast, that's the site of the drain which was put. So practically whole of the breast or half of the breast has been violated. Not only that, the scars are going beyond the mastectomy scar, so we have to take the scar much beyond, and ultimately the radiation field also goes beyond if radiation is required, resulting in higher dose to lungs as well as to heart, since this is the left side. Another young lady had a supraareolar lump excised with a periareolar scar, and the drain was right in the 6 o'clock position. Had to undergo mastectomy just because of this. So please, this is something which we should try and avoid. Now breast cancer diagnosed has lot of emotions involved. I am sure all of you know of these. Obviously it starts with denial, and as late as 2 days ago I had a young lady, 32-year-old, very active and almost at the peak of her career. She was just so angry, not ready to talk, just not ready to talk. I said, who is there in your family? Nobody is there. And her husband is sitting next to her. She said, no. I said, who is he? He's a friend. So that was the kind of anger she was having, just because she said, I have not done anything wrong, why it happened to me. Similarly, there are various emotions which are there, and here comes the role. You have to be a partner, because you have been with that lady for a very long time. Most of our breast cancer patients would come through you, from you, or referred by you, that she has a suspicion, she has a diagnosis, and they have been with you for OBS as well as gynae issues, and that is where I think they will listen to you a lot in form of assurance, counseling that things will be right, there is treatment available, it's not doomsday, and you have to handhold them throughout the procedure, throughout the treatment, as well as coordinate with the oncologist. So this lady is actually moving from a known territory to an unknown territory. Known means she is with you, she has known you for so many years, and if I may say that, it's like going from your Maika to Sasural. You don't know how people are going to be, what will come, and how things are going to turn out. So compassion with them and hand holding is very important. So before treatment begins, if you can put in a word of counseling, it helps us also. Fertility issues have just been discussed, and very close cooperation is needed between us IVF specialists and you, and as well as the patient, because we have to time it, whether we can give stimulation or not. There are hormone positive cancers, they have separate issues, and what kind of preservation is possible, whether the partner is available or not, and all those issues we have been discussing just over our last 40 minutes. Genetic testing, another very big issue. Not every lady who has breast cancer would need genetic testing, but good number of them would, and younger ones with family history definitely they would need. But just ordering a genetic test is not sufficient. We have to make sure that there is a pre-test counseling so that the lady understand the implications of the test results, whether the results are clear cut or ambiguous, and then what happens if it is ambiguous, what happens if it is positive, and what are the treatment implications. There are some ladies who just refuse to get it done because they say, come what may, I don't want to know it. That's the full stop there. And it is not only BRCA1 and 2, there are genes beyond BRCA. BRCA probably would involve 70-75% of the abnormalities found in breast cancer hereditary syndromes. Rest of them are found by other genes. So the time for multi-gene panel has come. It's not expensive as compared to doing only BRCA, and that is the order of the day. Excuse me. Coming to treatment options, I mentioned right in the beginning about IHC, and biology decides treatment over anatomy. So if you see these two patients, 50-year-old lady and a 48-year-old lady, both having similar size of lump, both having similar kind of nodal involvement, almost similar involvement, but they may be treated very differently based on what kind of tumor it is. The first one has a ERPR strong positive tumor and HER2 negative. However, the second one has a triple negative tumor, which is ERPR negative, HER2 negative. It could also have been ERPR negative, HER2 positive. Would be treated very differently. While the first one can actually undergo surgery upfront, if it is suitable, the size is suitable for conservation and patient wants it, definitely upfront surgery followed by adjuvant. The other lady without doubt would go for neoadjuvant chemotherapy, and that is where the role of immunohistochemistry comes. Now, conservation or mastectomy. Oncosurgery is often equated with mutilation, but that is not so. There has been a paradigm shift, and from maximum tolerable treatment to minimum effective treatment is the goal now, or is the motto. That is what is our guiding principle. We must give minimum effective treatment. Obviously we cannot compromise on efficacy of the treatment, but we need not give the maximum tolerable treatment, and the less can actually be more. Regarding breast conservation, we have large randomized data with more than 25 years of follow-up, which has said that there is no difference. More than 25 years. In fact, non-randomized but very large body of data says that breast conservation actually improves survival as compared to mastectomy. So please don't go back with that notion, but definitely breast conservation is at least as good as mastectomy. The other part of breast cancer surgery is axillary management, and there also we can de-escalate our surgery by doing sentinel node biopsy. This is an equipment on the left side which is a counter, because sentinel node biopsy we do by two different techniques. One is a blue colored dye and one is a radioactive substance. So this counter actually reads the radioactivity which is injected around the tumor, inside the tumor, periareolar. There are various techniques and all are okay. And on the right side you can see there is a probe wrapped up in plastic, which is a gamma probe, which is actually taking the radiation from those nodes which have picked up the radioactive material first. And this is the lymph node, which you can see is blue colored, is the sentinel lymph node. So we remove the sentinel lymph node, which can range from 1 to 5, subject them to frozen section, and if they are not involved, we need not go ahead completing the axillary surgery, thereby preventing the morbidity which arises out of axillary dissection, especially lymphedema and shoulder dysfunction. Now there are studies which have also shown that very minimal involvement of axilla also does not require axillary surgery. Sometimes now more research is also going on in those patients who have positive axilla but turns negative after chemotherapy. Can we save axillary dissection in those patients? Yes, there is an evidence. We haven't yet started that as a practice in India, but very soon we would be doing that as well. So that's the kind of scar you see. This is a lady with breast conservation surgery done. There is a periareolar scar, there is a small axillary scar. hardly visible and is almost looking as a normal breast. That's the axillary scar, very tiny scar of sentinel lymph node biopsy. The lymphedema rates, which are typically 20 to 30% post axillary dissection, come down to less than 5% with sentinel lymph node biopsy. So apart from mastectomy de-escalated to breast conservation and axillary dissection to sentinel node biopsy, so there are ladies where we can avoid chemotherapy, and radiation duration, which typically was 5 to 6 weeks, has now come down to 3 weeks. Then when we need to do little more to achieve much more, like oncoplasty, breast conservation I talked about. There was a time when we used to conserve the breast but do little oncoplasty to basically give a better cosmesis, and then preventing lymphedema after axillary lymph node dissection. So this is a lady who has had a breast conservation, not too bad a cosmesis, but for us surgeons I think it is not appropriate. This is obviously not good. So what can we do? There we use oncoplasty techniques, and it's a similar patient where we not only remove the tumor area, we also do some oncoplasty in the remaining area of the breast, and that's how you can achieve a very good cosmesis. Skin sparing mastectomies with whole breast reconstructions, at the same time giving a tummy tuck because the tissue has been taken from the abdomen. And finally, when we have done axillary node dissection, we know that lymphedema rates could be higher. There is a technique called lymphovascular anastomosis. The lymphatic channels which have been cut during surgery are identified, and they are anastomosed into a vein so that the lymphatic flow continues at a reasonable pace and avoids lymphedema rates. So this again, lymphedema rates come down to less than 5%. Finally, during and after treatment, support as well as rehabilitation is very much needed, and you have to be forthcoming in discussing about problems and hand holding them again. There are treatment related toxicities, premature menopause, sexual problems, hair loss, and there comes the role of support groups where we make the patients meet with each other, we meet them, we call experts for various topics, ranging from hair loss to lymphedema to other problems which they face during the treatment and after the treatment. And finally, my second last slide, stage 4 disease. Don't go with or don't have the pessimism for stage 4. Things have changed a lot. It's definitely not an immediate death sentence, and for many, if it is a favorable biology, they can go on for years and it can be actually labeled as a chronic disease. We have had patients surviving for 15-20 years after stage 4 diagnosis if they were strong hormone positive, HER2 negative, and they were treated properly. Even with more aggressive biology, now newer treatments have come, immunotherapy has come, some targeted therapies are coming, and the survival has definitely improved significantly as compared to what it was a couple of decades ago. So just to conclude, please use TrueCut and core biopsies under ultrasound guidance preferably, instead of FNAC, incision or excision biopsies. Once it is diagnosed, the journey actually begins here and doesn't end for you. As gynecologists, you are a partner in care, and we also will be helped a lot if you continue to be a part of their care. Biology supersedes anatomy, and that I think breast cancer exemplifies it the best amongst all the cancers. And the paradigm shift has taken place now. De-escalation of therapy, surgery, chemotherapy or radiation, all three specialties have de-escalated therapy, and breast conservation is at least as good as mastectomy in suitable patients. It is a multidisciplinary management, not only within oncology but also from outside oncology. Thank you very much.